Hello, ladies and gentlemen. Welcome back to our ongoing series of lectures on anesthesiology. In this lecture, we're going to talk about general anesthesia, and we're going to review many of the devices that we talked about in the last lecture, so you will get to see some of the devices and how they are used. We're going to start with our agenda for the talk. It'll include preoperative assessment of the patient, which is a very important aspect of the anesthesiologist's care of the patient. We're going to talk about evaluation of the airway, induction of general anesthesia, securing the airway, maintenance of general anesthesia, reversal of muscle relaxation if necessary, recovery from general anesthesia, management of pain, and recovery room care of the patient. So immediately before surgery or days before surgery, patients undergoing any form of anesthesia require an anesthetic assessment. This could be immediately before surgery if the surgery is a fairly straightforward, simple procedure and the patient is known to be healthy before you go ahead with the surgery. Surgery will be canceled at this point if the anesthesiologist is dissatisfied that the patient is safely prepared for surgery. So there's an incentive for surgeons to make sure that their patients are seen by anesthesiology in advance of their admission to hospital. In many hospitals, including my own, patients are seen days to weeks before surgery so that the anesthesiologist can assure that the patient is fully prepared for surgery. So what do we ask about? What do we do when we see these patients prior to the surgery? Well, we get a full history of previous anesthetics. We get a family history of anesthetic problems, particularly if there's any history of malignant hyperthermia or pseudocholinesterase deficiency. We examine the airway, lungs, and heart, and we do a general history and physical for other potential medical conditions, such as diabetes, heart disease, asthma, rheumatoid arthritis, etc. Almost any medical disease has some anesthetic implications. We're the airway experts, so it's really important that we maintain an open airway during surgery. One way of doing this is using a Goodell airway, which is the little hooked airway most of you have seen, goes in the mouth and holds the tongue forward. This is often useful in preparing the patient position for intubation. So after they're induced, but before intubation, you can use the Goodell airway. We're going to talk about the laryngeal mask airway, which is very useful for maintaining an airway during surgery, particularly in patients who are maintaining spontaneous ventilation. This device is also useful for maintaining oxygenation in the difficult airway situation. Additional helpers include the stylet, which I described earlier, and the bougie, which is basically a long, very thin device that can go through the endotracheal tube and can act as a guide for the endotracheal tube through the cords and into the trachea. And then a number of devices for visualizing the airway, including the standard laryngoscope, a device known as a glide scope, a Stort's videoscope, and the fiber optic bronchoscope. So part of the airway assessment is to do a Mallampati score. And the Mallampati score is extremely easy to do, and everybody gets it done. Basically, the patient should be sitting between 30 and 45 degrees, open the mouth as wide as possible, and extend the tongue as far as possible. They should not say "ah." If it's a Mallampati 1, you can see all the teeth, you can see the hard palate, the soft palate, the uvula, you can see right into the oropharynx. Mallampati 2, the uvula, the tip of the uvula gets cut off. It's a little harder to see the oropharynx, but you can still get a pretty good view. Mallampati 3, you've lost the uvula, and you can only see perhaps just a tiny bit of the oropharynx. And Mallampati 4, you basically see tongue and very little else. It's an incredibly easy test to perform, and everybody gets it done. Problem is, it isn't very sensitive, and it doesn't really tell us very often that we're going to have problems. When the patient arrives in the operating room, they have a blood pressure cuff placed on them, cardiograms placed, pulse oximetry and end-tidal carbon dioxide level are always done. And in the United States, it's a required monitor to put a temperature probe on the patient or in the patient's mouth or nose. Make sure an intravenous is in place. Give a small dose of a drug such as fentanyl, 1 to 3 micrograms per kilogram is what I normally use. The induction drug in a healthy individual who's hemodynamically stable, my preferred drug is propofol. I use 2 to 2.5 milligrams per kilo, and I follow this immediately with rocuronium 0.6 milligrams per kilo, which is a moderate but not large dose of rocuronium. When I'm doing a patient that requires neuromuscular blockade, I often use a nerve stimulator, such as the one shown in this picture. It's hooked up to the forearm. The current is adjusted through the stimulator, and you examine the thumb for twitches as stimulations occur. And the usual rate of stimulation is 4 twitches over 2 seconds. This is called the train of 4. And the assessment of the train of 4 can give us some indication of how deeply paralyzed the patient is, whether it's safe to proceed with intubation, whether it's safe to proceed with surgery, or at the end of the case, whether it's safe to attempt to reverse the patient. I've mentioned bag and mask ventilation a number of times in these lectures, and this is what it looks like. Basically, the bag is on the anesthetic circuit. You've seen that in previous pictures. The mask is just a standard medical mask. It's placed over the patient's face to produce a seal around the nose and the mouth. The thumb and forefinger force the mask down over the face. The middle finger and other fingers lift the chin up, and it's important to pull the chin right up. And you can see that this anesthesiologist is bagging with his or her right hand while positioning the patient's face and head so that it's easy to ventilate the patient. These are laryngeal mask airways. These devices are meant to sit above the glottis, so not through the cords of the patient, not into the trachea, but above the trachea, and they hold the epiglottis up, and hopefully, if they're perfectly in position, look right down through the cords into the trachea of the patient. The beauty of this device is that even when it's not perfectly positioned, it's often usable, and you can get out of a lot of trouble using this device, even in situations where you're having great difficulty with intubation. This is how it works. The Dr. Brain, who invented this device, recommends the following technique, and I know because he was in my hospital for a number of weeks and taught myself and my colleagues how to use this. Basically, he thinks that you should deflate the cuff of the laryngeal mask, push it down while you're deflating it so it's completely flat, and then take your index finger, put it down right under the lip of the cuff, and pass the device into the mouth, putting firm pressure on the palate as you proceed into the back of the airway. And it's basically this motion, kind of back and then forward again. And you can push the laryngeal mask right down into the upper airway, and you can see the mask is in place. It's not occluding the airway, it's above the airway, and it's holding the epiglottis out of place. It's very useful. These are standard laryngoscope blades. The blade on the right is a Macintosh blade. Most of us use the Macintosh blade pretty much routinely. The blades on the left are the Miller blade. I can tell you I haven't used a Miller blade in probably 30 years, but there are some anesthesiologists who swear by it and use it in preference to the Macintosh blade. And you can see the various sizes. They go all the way down to very small for children. And in small children, the Miller blade, the straight blade, is often the preferred blade to use. These are endotracheal tubes. These come in various internal diameters. You can see that there's a cuff at the end of the tube. This is inflated with air once the tube is in place, and this acts as a seal to prevent material passing down through the trachea into the lungs or coming the other way up around the endotracheal tube, and it basically seals the airway and allows ventilation to occur. This is the position we get the patient in before we intubate. So we try to flex at the lower cervical spine, so down at C6-7, flex forward, and then extend at C1-2. And this is known as the sniffing position. And you have to adjust that pillow under the head, sometimes underneath the the shoulders, to lift the shoulders, to improve the extension, to get a good airway. You should always have something under the head. One of the fallacies of people who don't intubate frequently is that they throw the pillow across the room to get it out of the room, and then an anesthesiologist has to come in and put it back and intubate the patient. The laryngoscope is placed on the right side of the mouth, avoiding touching the teeth. It pulls the tongue to the midline and it's lifted. It's never, ever do you turn your wrist when you're doing this. You put the laryngoscope in and you lift. And the lifting lifts the tongue and the mandible and allows the cords to be seen. And you can see in this example, the cords are very easy to see. And that's a dream intubation. That's going to be very easy to do. So in this situation, you can see how difficult you can make things by positioning the patient incorrectly. In the picture on the left, the patient doesn't have a pillow. I just finished mentioning how important that is, but you can see what's happened here is the neck's too flexed. The lower part of the neck is kind of pushed forward and you can't get good atlanto-occipital extension. In the second picture, it's better, and there should be a fairly straight line from the mouth down the airway, and that you can see in the third picture. There's a fairly good view, but it could be argued that this is too extended, that they've extended the whole neck rather than just the atlanto-occipital area. So the Macintosh blade, the curved blade, should be positioned anterior to the epiglottis in the vallecula, that's the base of the tongue, and should not contact the epiglottis. The Miller blade, the straight blade, on the other hand, actually lifts the epiglottis, and you can see that in the picture to the right of the Macintosh blade. It actually lifts the epiglottis, and there's some hemodynamic changes that can occur when you do that, particularly vagal stimulation, so you can get bradycardia and things that I'd just as soon avoid, so I don't use a straight blade. This is what you should see. The endotracheal tube is at the top. You can just kind of see that shiny device above the epiglottis. The epiglottis is that organ sticking out towards you, and it's all lifted up, and you're looking right down at the cords. Easy to intubate that. This position, where you're looking at the cords, can be then further categorized according to its McCormick-Lehane classification. And the ideal position is a class 1, which is perfect view of the cord. You're looking right at the arytenoids, which are the little bumps at the bottom of the slide, just at the base of at the bottom of the cords, and you're looking right down the airway. That's the ideal position. And you should be able to intubate in that situation very quickly and easily. Class 2 is also pretty good. You've got a little less of a view. You've got the epiglottis coming down a little bit over the cord, so you're losing the top of the cord, but you're still seeing 50% of the cords, and you should be able to intubate. It's when you get to 3 and 4 that things become more difficult. With a class 3 airway, you may see a little bit of the airway, and this is where a bougie sometimes helpful, because you can slide the bougie underneath that epiglottis and get it in through the cords and then pass the tube down over the bougie. But this is a difficult situation. And then the worst is class 4, where you can't see the airway at all. All you can see is epiglottis. Sometimes what you see is the epiglottis kind of stuck to the posterior pharyngeal wall, and it just won't move. And this is where you're getting into trouble with intubations. So this is how we can use an LMA to intubate a patient. We can either use a standard LMA and pass a narrow gauge tube down it, about a 6, and it's a tight fit. I've done this, and it's a tight fit, but you can get it down. You should use the fiber optic scope to look and make sure that the end of the laryngeal mask is actually adjacent to the cord, so you can see where you are, because as I mentioned earlier, even when the LMA is out of position, you can sometimes ventilate okay, and with the bronchoscope you can tell exactly where you are, so you could force a tube down through that. With the intubating LMA or the fast track LMA, it comes with a size 8 endotracheal tube that is made of silastic, which is a plastic material that slides more easily. It's got a bigger barrel than a standard LMA, and you can get the 8 tube through. So particularly for a man, that's a better size than a 6. A 6 is small for a man or woman. So this is intubating through the nose, and it's interesting when you pass a tube down through the nose after you've prepared the nose, as I mentioned earlier. Sometimes you don't have to do much of anything to guide it towards the curve. The natural shape of the endotracheal tube is such that you can often just push it down, look through the mouth, and you'll see the tube coming past the palate into the oropharynx, and it comes forward very nicely right through the cords. If it doesn't, you use this right angle forceps called a McGill forceps to lift the tube end, the tip of the tube, and direct it down through the cords. So this is intubation using fiber optic bronchoscope, both orally on the left side of the diagram and nasally on the right side of the diagram. And it basically just shows how the fiber optic scope is passed down through the airway, and then the tube is slid down off the scope, keeping the scope in place until you've got the tube down off it and into the airway. And then you can remove the scope, check for position of the tube, and hopefully you'll be home free. So this is what the cords look like through a bronchoscope. Look basically the same as the way they looked just using a Macintosh blade. The only thing is you're closer. You can see you're a little bit closer. And if you were doing an awake intubation, this is where you would spray a little bit of lidocaine on the cords before you pass the bronchoscope any further. And in this picture, you can see the endotracheal tube going underneath the epiglottis and through the cords. And that's what you should be able to see once you've intubated and you have another look just to make sure you're in the right place. Once you think the tube is in place, inflate the cuff and listen for a leak around the cuff. The inflation should be just enough to stop the leak. Look at the chest wall. Is it moving? Look at your end-tidal CO2 monitor. Are you getting CO2 back? Look at the tube. Are you getting condensation of water vapor on the inside of the tube? You won't get that if you're in the esophagus because there's no water vapor to come back from the stomach. So check for those things, and then listen to the lungs. Listen bilaterally, listen well out into the axillary area, and make sure you've got air entry. This is a picture of 3 vaporizers that are commonly used in anesthesia. They are all drug-specific. They'll only manage one drug. They're calibrated for atmospheric pressure or whatever the atmospheric pressure is in the area in which you live. The temperature, they change their delivery of vapor dependent upon the temperature in the room. So if it's in the middle of the summer and very hot, they adjust to that. They also adjust to the flow that you set through them. And each is calibrated annually, as I mentioned. I know the one on the left is for isoflurane, and I know that because it's got a purple band on it, which is the isoflurane color. The one on the right is for sevoflurane, and I know that because it's got a yellow top, which is the sevoflurane color. And the one in the middle is for desflurane, and blue is not a particular color for any vapor, but I know that the device on the lower left of the vaporizer is the filling port for a desflurane vaporizer, and it doesn't exist on any other kind of vaporizer. So that's easy to work out. So, what vapor are you going to use? So let's start with isoflurane. Set the inspired level of isoflurane at 1 to 2%, and then adjust according to the patient's hemodynamics. All of these vapors enhance muscle relaxation. Isoflurane itself is too pungent for inhalation induction. Common to get tachycardia with isoflurane, but you get no myocardial depression. Slow onset of action, slow recovery, bit of a hangover. Desflurane is not as potent as isoflurane, so you have to set it at a higher initial level, set it at 5 to 7%, and again, adjust to the patient's hemodynamics. It also enhances muscle relaxation, as all the vapors do. It also is too pungent for inhalation induction. Tachycardia and hypertension occur if concentration is raised quickly. If you don't do it quickly, if you only raise it a little bit at a time, you don't get tachycardia and hypertension. There's no myocardial depression. Again, it's the fastest onset and recovery of any of the vapors, but it requires a heated vaporizer, which is a more expensive device and requires more careful calibration. And finally, sevoflurane, set the inspired to 1 to 3%, and again, adjust to hemodynamics. It also enhances muscle relaxation. It's an excellent choice for inhalation induction as its smell is mild, and we talked about that in an earlier lecture. It produces little change in heart rate, no myocardial depression. It has an intermediate speed of onset and recovery, fairly quick actually, but not as quick as desflurane. And it's been very popular in pediatric anesthesia because of its property as an inhalation induction agent. Reversing muscle relaxation. We talked about reversing muscle relaxation in a previous lecture. But as an overview of anesthesia in general and maintenance of anesthesia and leading up to recovery, remember to give narcotic analgesics during surgery so that the patient is comfortable when they awaken. And many of us give a little extra right at the end of surgery so that as the patient's waking up, they'll have a minimum of pain. Monitor muscle relaxation through surgery and reverse usually, because it's not expensive, with an anticholinesterase inhibitor such as neostigmine, and you have to add in an antimuscarinic such as glycopyrrolate. Reduce or turn off the vapor, but continue to ventilate the patient until the patient begins to make ventilatory efforts on him by himself or by herself. And let them take control of the ventilation as they continue to recover. So initially, you're bagging them or letting the ventilator control their ventilation, but as they begin to make more effort on their own, you back off a little bit on the bagging, and then ultimately they should be able to control ventilation on their own. Extubate the patient when the patient is awake and responding to your voice. So I always talk to the patients as they're waking up. We usually call their name. And if they open their eyes and I ask them if they're having pain or, whatever, and they respond appropriately, I'll extubate. So you deflate the cuff and you pull the tube out. But don't extubate too soon. Our patient may become apneic and require manual ventilation, and laryngoscope may occur, which is spasm in the muscles in the larynx, which can make ventilation very difficult. Remember that often the only reason the patient's breathing at the end of surgery is because they've got the tube in place and it's irritating them. As soon as you take that tube away, they have no reason to breathe anymore. So you have to make sure they're actually responding before you take away the tube. Place an oxygen mask on the patient, move to a stretcher, and transport the patient to the post-anesthesia care unit or PACU. Maintain verbal contact with the patient during that transfer process. When you reach the PACU, you should communicate with the nurse the information that he or she needs to continue to care for the patient. So, patient's identity, surgical procedure, other medical problems the patient may have, any anesthetic concerns, any allergies the patient has, and really what you expect to be the recovery phase for this patient. You provide orders for pain management and management of nausea and vomiting, and provide orders for control of comorbidities. So you may say patient's blood pressure is allowed to rise to such and such, but beyond that, call me or give the following drug. Same with the heart rates, and you don't want to leave the patient without the nurse having information that will allow proper care for the patient. If your communication is clear, the nurse should be able to anticipate potential problems and notify you if any occur. Recovery room nurses are extremely skilled, and they rarely need to call the anesthesiologist. If they do, pay attention, because if they're having trouble, you need to go and see the patient and deal with them. So in summary, in this lecture, we've discussed the preoperative evaluation of a patient, management of general anesthesia from induction, airway management, maintenance, to recovery. We've talked about the transfer of the patient into the recovery room and the support that you are required to give to the recovery room nurse to allow for proper care of the patient.